a large number of what our patients will be receiving once they do progress on ibrutinib, so I think that this sort of fits very nicely. This, of course, is the wrong title slide. So I do want to talk about two studies primarily. The first one is the M13982, which is Venetoclax monotherapy in patients with relapsed CLL with 17p deletion. This is the pivotal study that led to the phase 2 approval, or the approval of ibrutinib off of phase 2, of Venetoclax off of phase 2 data. The second study is the M14032, which is a study actually presented by Dr. Jones at ASH recently, looking at Venetoclax monotherapy in CLL post-BCR antagonist. So Venetoclax, formerly known as ABT199 or GDC0199, is actually a derivative of ABT263. These are all BCL2 inhibitors. And what's important to keep in mind here is BCL2 is a very important anti-apoptotic protein. And in essence, the BCL2 family members, the pro-apoptotic interfere with the anti-apoptotic ones, and in essence, create a balance. And when you have a balance that favors apoptosis, you end up getting pores generated in the mitochondria, loss of mitochondrial membrane potential, and apoptosis. So here we have an inhibitor of BCL2. BCL2 is one of the most important anti-apoptotic proteins. All of a sudden, the pro-apoptotic members of the BCL2 family, BAD and BAX primarily, can come together and induce pore formation and lead to apoptosis. One of the problems that we have with Venetoclax, which is a relatively interesting problem to have, is tumor lysis syndrome. All right, so it's a double-edged sword. In the phase 1 study, which was done as a traditional phase 1 study, patients were started off at a low dose and then escalated up in subsequent cohorts. So we had patients receiving basically 400, 600, 800 milligrams at time of treatment initiation. And in essence, we had 2 patients die of tumor lysis. And these were patients who actually died within literally 24 hours of receiving their dose. With a new tumor lysis mitigation strategy, as we call it, we've actually had no clinically significant tumor lysis, and we've had only 1 episode of biochemical tumor lysis. So the important thing is with these safety measures in place, Venetoclax can be very safely and effectively used. So now the idea is that you start off at 20 milligrams for week 1, and provided that you don't have any biochemical evidence of tumor lysis, you escalate week by week to 50 to 100 to 200 to 400 milligrams, and 400 milligrams is currently the approved maximum dose. We do have a trial ongoing looking at using 600 milligrams in patients who don't have an adequate response on 400 milligrams, but at the current time, 400 milligrams is the maximum dose. Now, what's really also important besides this dose escalation is the tumor lysis prophylaxis. So patients are divided into either low, medium, or high tumor burden based upon a lymphocyte count of greater than or less than 25,000 and lymph node size of less than 5 centimeters, 5 to 10 centimeters, or greater than 10 centimeters. And you can see here, based upon their risk category, the hydration that's recommended, and I would like to point out that for the high-risk category, it really is recommended to have intravenous hydration in the hospital. With allopurinol, and in the high-risk category, once again, adding respiracase. And you could see the blood monitoring that's required, which, is sometimes feasible if you happen to have your office right below the chemistry lab, like myself. So looking at the pivotal study, the M13982 study, so this was a phase 2 study, and it's important to keep in mind that this is a phase 2 study. Key inclusion criteria were relapse refractory CLL, 17p deletion, ECOG performance status of less than 2, adequate hematologic parameters, and of course adequate renal function. And then you can see the exclusion criteria there. So looking at the baseline characteristics, you can see here that overall this was a relatively typical patient population of CLL patients. The median age is 67. All these patients had received prior chemotherapy as indicated. And you can see in terms of the risk category, what I want to highlight is the 80% of the patients were medium to high, and they were split, primarily 50-50 between medium and high for that 80%. So overall, looking at the independent review committee, the overall response rate was about 80%, with 8% CRs, 3% nodular PRs, and 69% PRs, and importantly, 21% no responses. One of the entities that I'll focus on in a little bit is an entity of MRD negative partial response. And I think that's a very important thing that we need to keep in mind, because all of a sudden, the IWCLL response criteria might not be as helpful as we are used to it being. Now, 25 out of 48 patients had no CLL in the bone marrow, and 18 out of 45 patients who were assessed were MRD negative in the peripheral blood. So we're actually seeing very dramatic and very deep responses very quickly in these patients. And you can see here the change in the lymphocyte count. And what I really want to emphasize is, here's the 4,000, but there's obviously a lot down here that are different. So in my own experience, what I find is these patients who don't come all the way down to really almost being MRD negative are the ones that are going to progress. And so the classic patient who has a lymph node mass that might go from 5 centimeters to 3 centimeters, but is MRD negative, is going to do extremely well. But the patient who has no lymph node masses and has a lymphocyte count of 2,000 is going to progress somewhere between 12 and 18 months. And here you can see the change in the lymph node sizes. And what's really interesting is in the patients who are MRD negative, over time that lymph node will continue to shrink. And so we've had a few patients who achieved excellent responses with MRD negativity and still very sizable lymph nodes, but over time those lymph nodes just continue to shrink. And so looking at the patient disposition, you can see here that 37 patients have discontinued Venetoclax, 22 to disease progression, and that was split between Richter's transformation and CLL progression, 11 and 11 each. And remember that this is a 17p deleted population. And so Richter's was a real issue that we had to confront with these patients. 9 had adverse events and others for a myriad of other reasons. And then 18 deaths, 14 of which were due to disease progression. So looking at the IWCLL response, you could see the time to response was actually very quick, 0.8 months, and the median time to CR, and of course this is changing as patients continue on therapy, was 8.2 months. And as I mentioned, MRD negativity, you could see 45 patients tested, 18 achieved MRD negativity in the peripheral blood. And here you can see the MRD negativity for the patients that were in complete responses, up to about 50%. Now looking at progression-free survival, I apologize, the estimate's not there, but at 18 months, we're up to about 55%. You can see here that what we really are going to look for, given the fact that these are patients who have very deep responses, in patients who really by the end of 12 months, you probably know whether or not they're going to enjoy long-term remissions or whether or not they're going to progress, is that hopefully this will plateau. And that if we talk about a 50% plateau in these patients, that would be really a successful use of an agent in this patient population. So duration of response is quite long, and here you can see, once again, the PFS with 72% at 12 months. Now, treatment-emergent adverse events, overall the drug is really well tolerated. You can see the adverse events listed here. I really believe that GI and neutropenia are the two most classically drug-related adverse events. So we do see some nausea and diarrhea with Venetoclax, and we also do see neutropenia. Just speaking now specifically to ones of interest, so we talked about tumor lysis. There was no clinical evidence of tumor lysis. 2 patients did have a dose interruption based upon investigator-decided assessment that they had ongoing laboratory evidence of tumor lysis. Grade 3 or 4 neutropenia was seen in about 40% of patients, 22% of whom had baseline neutropenia. The management was either with dose interruption or just the use of Neupogen. 72% of patients did have infections, and remember that this was a very heavily treated CLL patient population, so without a control arm, we don't know how much of that is Venetoclax related. But the most common were just upper respiratory infections, nasopharyngitis, and urinary tract infections. And serious adverse events happened in 55% of patients, including fevers, autoimmune hemolytic anemia, pneumonia, and febrile neutropenia. So that's the pivotal study that led to the approval of Venetoclax in 17p-deleted CLL. And I do think that there's an important role for Venetoclax in its rapid reduction of tumor burden. One of the problems that we have with an agent like ibrutinib is a very slow time to getting a deep response. So if we think of CLL as a time bomb where we have a certain period of time during which mutations may occur that may cause the CLL to actually behave more aggressively, either transform or develop a point mutation that makes it resistant to the ibrutinib, having a rapid reduction in tumor burden could be important. And based upon what we talked about earlier with 17p deletion, those are a group of patients who I do think might benefit from a more rapid tumor reduction. Now looking at the next patient population, and these are patients who are progressing on BCR antagonists, primarily or exclusively ibrutinib and idelalisib. You can see here that this was a phase 2 study, and this was presented by Dr. Jones at ASH this past year. And patients were either relapsed after or refractory to ibrutinib or idelalisib. And it's important to recognize that patients who were on ibrutinib or idelalisib and had the drug stopped for any reason and then progressed were able to go on the study. So these aren't people exclusively refractory to idelalisib and ibrutinib. And you can see the inclusion criteria here. And looking at the patient characteristics, you can see here Arm A, remember once again, are the ibrutinib patients, and Arm B are the Venetoclax treated, the idelalisib treated patients. You can see 49% were 17p deleted in the ibrutinib arm, whereas 10% were in the idelalisib arm. You can see here the rest of the characteristics. What I'd like to point out is that a lot of patients had both ibrutinib and idelalisib, and that they were put in an arm based upon their most recent therapy. Here you can see the patient disposition. Out of the 43 patients, we had 18 patients discontinuing the ibrutinib arm and 4 in the idela arm, 12 of whom were related to disease progression. And overall, you can see the response rates were actually quite high. We see a 61% overall response rate in the ibrutinib arm and a 50% overall response rate in the idelalisib arm. And of course, these response rates are going to evolve over time as we see patients go from partial response to complete response, or just have further reduction in their lymph nodes and go from stable disease to a partial response. Here you can see the swimmer's plot for the disposition. Median time on study was 13 months for the ibrutinib arm and 9 months for the idelalisib arm. And you can see here that the vast majority of patients remain on drug. All right? And with the idea that these are patients who had deep responses and may actually do well long term, hopefully these are patients that will continue to do well. Here you can see in the efficacy, the duration of response, the PFS, and the overall survival were not reached at 11.8 months. The estimated 12-month PFS for all patients was 80%. And what I'd like to point out, and this is sort of a little bit unusual, for this MRD status assessment, they actually went below 10 to the minus 4. But what you can see here is that there was a significant number of patients who did achieve MRD negativity. And these were MRD negative in the peripheral blood between weeks 24 and 48. So these are patients by 6 months that we really know that they're going to do extremely well on Venetoclax. 5 patients who did demonstrate sustained MRD negativity in the blood subsequently had a marrow, and 1 was MRD negative in the marrow, and the 4 obviously were MRD positive. It remains to be seen whether with continued therapy they will also achieve MRD negativity in the marrow. Safety-wise, there was no clinical tumor lysis syndrome observed in these patients. The 1 patient with a high tumor burden met the criteria for having laboratory tumor lysis syndrome. You can see the adverse events here are sort of similar to what we saw in the earlier phase 2 study. And so just in conclusion, in these patients who progress on ibrutinib and idelalisib, we are able to rescue a significant number of them, and it actually seems to be, quite telling that with these patients, you can actually induce deep responses and really know by months, 6 to 12, whether or not this is a patient who is going to be able to go on and enjoy long-term remission or really require additional therapy. And I think that this is an important thing to keep in mind when we are sort of thinking about what to do next in our patients. And so this is a way to sort of predict at 12 months what you might need to do next. And I thank you.